Good evening and good afternoon to everyone joining us in from across Canada or abroad. It's really great to have you on another continuing or NSWOC and WOCC Institute continuing education webinar. We want to thank Medline today for being able to make this education possible. And of course, to our guest speaker, Paulo, who will introduce in just a few moments. But before I do, what I'll do is get everyone to click on that chat button in your Zoom toolbar. If you don't mind just typing in where you're tuning in from today. My name's Troy, and I'm the Director of Operations for Nurses Specialized in Wound, Ostomy, and Continence Canada. I'm tuning in from Ottawa, Ontario here, and I'm really happy to be with you on here again with you. We're going to be having a webinar, as you know, presentation first. We're going to then have a Q&A session at the very end. So what I'll get you to do is instead of clicking on the chat button, if you have a question, click on the Q&A button, and that'll make it super easy for us to organize and get to as many as we can at the very end. Today's webinar is being recorded, so if you have to leave a little bit early or if you want to share this with a colleague in the future, you will be able to access it again on our NSWOC.ca website. You're also going to be receiving a certificate of attendance today. Just give us a day or two to get those into your inbox, but we will be sending that to you along with a few helpful resources post-webinar as well. So without further ado, I'm really happy to introduce our guest speaker today. It's Paulo de Rosa, who many of you will already know. He'll be talking about enhancing pressure injury prevention protocol, moving beyond the basics. And Paulo is a clinical nurse specialist in wound care at Parkwood Institute, part of the St. Joseph Healthcare system in London. And he holds a Bachelor of Science in Nursing and a Master of Clinical Science in Wound Healing from Western University. Paulo is a registered nurse through the College of Nurses of Ontario and is certified as a nurse specialized in wound, ostomy, and continence, of course, by NSWOC and certified through the CNA. With over 20 years of clinical experience in acute care and rehab, Paulo has deep expertise in surgery, chronic disease, mental health, pediatrics, spinal cord, brain injury, specialized geriatrics, and complex long-term care. He also served as NSWOC's president in the past and actively contributes to NSWOC, to Wounds Canada, and to the RNAO as well. Paulo has contributed to national and international best practice guidelines in venous leg ulcers, urinary diversion, and pediatric incontinence-associated dermatitis, with publications in Advances in Skin and Wound Care and the International Wound Journal. He speaks frequently at NSWOC, at Wounds Canada conferences, and other national conferences across the country. And at Parkwood Institute, Paulo is involved in professional practice, quality control, and program-specific committees. Outside of work, he enjoys gardening, sports, and handyman tasks. He's a devoted father of three, recognized for his leadership in professional development and dedication to advancing the wound, ostomy, and continence specialty through clinical practice, education, and research. And with that, I'll pass over the mic and the slides to you, Paulo. Thanks for being with us today.
Very good. Thank you so much, Troy. And I want to also extend a big thank you to everyone online today. I am aware that we have many people across Canada and as well quite a few international folks joining in. So I welcome you and I thank you for participating in this. I'll start just by with a little disclaimer that I am being sponsored by Medline for this webinar. However, the results of this OptiView evaluation occurred way before the plan to do this talk and is not in any way influenced by it, and there's no bearing on the outcome. So it's just I had this evaluation done, and then just recently was asked by NSWOC and Medline to present on some of the results. In Canada, thousands of patients each year endure pressure injuries, not as an unavoidable outcome, but as a consequence of misprevention in many cases. Behind every statistic is a human being, someone who will take longer to heal, who will lose trust in our system, and who may face complications that threaten their way of life. Pressure injuries cost our healthcare system millions of dollars, but the true cost is measured many times in human suffering. We know how to prevent them. The time is to act now, not tomorrow, not in the future. And it starts with awareness, commitment, and change. Now, this might seem like a strong statement that I have here, where it's, we're saying that it's a failure, that pressure injury is more than just a wound. But it is, in a way, a failure from all of us, from the system, to protect, failure to see, and sometimes to act in a timely manner. It's the silent suffering of a of a patient left unseen, a preventable harm that speaks a lost dignity and prolonged pain and opportunities missed. WOCC Canada, in their best practice recommendations, identifies that only about 10.8% of patients at risk actually receive fully adequate preventative measures while they're in bed or while sitting. So without further ado, these are the objectives for our session tonight or today, depending on where you are. Pressure injury issues in healthcare. Now, I am going to focus on Canada and Ontario. This is what I'm more familiar with, but certainly I'm sure many of this applies across the globe. I'm going to go over some strategies and guidelines for prevention of prevention and management of pressure injuries. I'm going to go through the protocol summary and the process for the OptiView evaluation that I did. I will look through some of those results and then talk a little bit about OptiView as an adjunct to pressure injury prevention protocols. And then lastly, we'll have a summary and some key points before the question period at the end. So you can see this is an old study here that shows an overall prevalence of 26%. However, after doing extensive searches, it's very difficult to find consistent data on recent trends of pressure injury prevalence across Canada. There's just not enough. There's underreporting. There's many different reasons for it. So I just thought I'd put this here and just give an idea of what we have. And hopefully, trigger some further studies to obtain that data. In Ontario, I do want to highlight some things here because this is part of the population that I deal with, and you can see that according to the health quality outcomes of Ontario, in long-term care, there's about almost 19% prevalence. And spinal cord rehabs, which is another group that I deal with a lot. These patients have a 26% incidence, and this is recent data. This is like from just last year that they've determined this. And the study that did this had over 1,700, so 1,700 spinal cord injury patients that were discharged, showing that 26% incidence. So it's pretty high. It is a very high risk patient population. But yeah, it's unfortunate that many of these occur. The other important factor, and this is maybe part of the reason why we don't have a lot of consistent data across Canada, because RNAO back a couple of years ago reported that the prevalence varies a lot. And as you can see there, 0.4 to 14. That's just the variance between the reporting that has been established across Canada. So there's different reasons for that. Things like different assessment tools, documentation and reporting practices, and then the variations even within a province between the different healthcare sectors, such as acute care versus community versus long-term care. So just different reporting systems kind of contributing to that lack of consistency and understanding of what we're dealing with. There's still a big impact. I think these numbers might even be a bit conservative. These were taken from WOCC Canada in one of their guidelines and management documents. But there's still an amount missing here. There's one that cannot be put into dollar signs. Quality of life and suffering for patients and families. That's priceless. That's endless amount of money that can't be accounted for. But what do we have? We have some key Canadian guidelines for prevention, and we've had guidelines for a long time, and we have really good guidelines with, as you can see there, the main associations like RNAO, WOCC Canada, NSWOC, the Health Quality Ontario, and then even accreditation has has a big impact on the quality and the issue with pressure injuries. So I'll just go over some of these individually, just kind of highlight some key points, but I will say that they're all sending the same message. The message is prevention. Prevention is key when it comes to pressure injuries. So what does RNAO say for key recommendations? Well, conducting a risk assessment on admission and then regularly thereafter, using validated tools such as Braden or Norton scale, implementing a structured skin care regimen, and then repositioning schedules tailored to individual needs. So super important to have these, because I find a lot of times that's part of the problem, is that the repositioning maybe is just isn't occurring as often as it should. Using pressure redistribution surfaces, specialized mattresses, cushions, etc., all part of those key recommendations. And then the nutrition screening and support, because obviously it's been identified that the nutrition, our skin needs a lot of nurturing, and nutrition is a big part of that. Therefore, if it's lacking, especially with our elderly population, then they're at increased risk of pressure injury development. And then lastly, the interprofessional collaboration for prevention. We need everybody. We need everybody, from leaders to all the different professional people within the settings that are dealing with patients. And just to kind of highlight, RNAO utilizes key stakeholders, which are often members of other associations such as NSWOC, WOCC Canada. These are members that contribute to produce thorough guidelines and recommendations. Thus, this is considered the gold standard in Canada. So we're just going to briefly look at what WOCC Canada is recommending, and this is again fairly recently, focusing on holistic, patient-centered care, with a strong emphasis on prevention at the system level, such as care protocols and early risk identification. I want to highlight some things here, like the care protocols, because this kind of ties into the plan that I have for developing protocols within my organization. And we need to, they need to be tangible, these protocols, clear-cut outlines that the institution needs to abide by. The other component of the recommendations, and it's a healthcare provider education and organizational accountability. There needs to be a leadership accountability within the organization to be able to make these things happen with these protocols, and then hopefully reduction in pressure injury incidents and therefore prevalence. The other point that I'm highlighting here is recommending the use of advanced dressings. So the advanced dressings they're not by themselves what's going to solve the problem, but they should be used in conjunction with the gold standard in order to achieve another step of prevention that is required for these patients. Quickly going over the NSWOC guidelines. Again, you can see the risk assessment, comprehensive risk assessment as a key component, the use of support services, as mentioned as well by RNAO. And then this one here, the microclimate management, is another one that I wanted to highlight as a key factor, because this is, again, another very important contributor to pressure injury development and the condition of the skin under these microclimate conditions. And then lastly, patient and caregiver education, as well as prevention bundles for acute and long-term care. When we're looking at the Health Quality Ontario, they're defining quality statements and indicators for early identification, risk assessment, and repositioning. Again, you can see a theme here with that relates to the prevention, and then patient-centered approaches. So risk assessment is definitely a key component that you see a common theme throughout all of these different groups. And lastly, Accreditation Canada, the pressure injury prevention is one of the ROPs, one of the required organizational practices, and it's been part of Accreditation Canada for quite some time now. But are we investing enough nationally and provincially in order to achieve this type of prevention? So they are highlighting risk assessment tools and early interventions, as well as documentation, which I find sometimes is a big part of the issue. Is we're documenting or not documenting enough, and documenting very differently. So I'm now going to move to the actual evaluation protocol that I did for this specific product that we're going to be talking about today. And I really want you to keep in mind that this is not going to replace anything that is being recommended or anything that's being considered the standard of care. Those things need to be in place. They are a must. This is an additional item that might be useful. And this is a concept that's started like a long time ago, not just with the OptiView, but with other dressings many years ago, where it's just an additional support for the standard of care in order to achieve those goals. So I created, based on some criteria, a protocol summary. This is the sheet that had some inclusion and like exclusion criteria to determine who would be eligible. I really wanted to check the use of this with the protocols in place, but also with those patients that were at higher risk. So as you can see, one of the key factors and criteria of having the patients trial this product was having a Braden score of 15 or less, which is considered moderate to high risk for pressure injury development. Okay, so this was the outline for the case study that we were doing, and then we had next the evaluation forms that I went through. These were provided by Medline. They had a standard evaluation form that captured things like ease of application, patient comfort, ease of removal, and then length of wear time, ease of skin checks, and then the overall product performance. And you can see there was basically three answers to each of those questions or each of those categories, and it would be either it's clinical unacceptable, clinically acceptable, or superior, meaning it met or went beyond the expectations. And then they also had an opportunity to provide further comments that maybe were not captured within the questions of the evaluation form. So the next step was then to have product. I had accessibility to three sizes: the round, the regular sacral, and the large sacral, where the round was used in different areas aside from the sacrum or buttock area. So in prior to actually starting the evaluation, and when I met with, we went to several units. We had several informational sessions that took place at each unit that was determined high-risk areas like the spinal cord injury unit, complex care, and specialized geriatrics at Parkwood Institute. And we had several sessions trying to capture, different nurses at different times in order to have everybody understand the protocol and the plan for this trial of this or this evaluation of this product. The results, as you can see, we had quite good results. I will show you some other information, but all patients with the evaluations form were captured here. We had about 21 evaluation forms. Some patients, as you can see there, with more evaluations than others, really dependent on their stay. Some were discharged, some were moved, some had other issues that required the dressing to be stopped. But most of them were related to discharge. And you can see I have them labeled A1, A2, A3, etc. So the alphabet is really the different patient, and then the 1 to whatever number would be the number of dressings that they actually had. One of the things that was interesting with this um, evaluation was I had clear criteria that the dressing was to be used up to 7 days. However, I found that with some of the evaluations, there were cases where there was dressings left in place for, one of them had it like 13 days, and there was a couple at 11 and some at 9. So it went beyond. So in order to get just a fair kind of wear time, I accounted, this is what my further right column is indicating. I counted for a max of 7 days, because that would be, in a protocol, that would be what I would be recommending. So the average wear time was about almost 5 days. I had 3 patients that were excluded from the results due to lack of evaluation forms. I had a few forms that were just had partial completion, like 1 or 2 areas where maybe weren't applied, but then it wasn't completed after that. So despite not having any pressure injury development from those patients, I did exclude them just because I didn't have complete data to be able to make a fair evaluation of the dressing. Here you can see that there was the scoring of the different evaluation forms. We had a total of, like I said, 21. In the ease of application, had pretty much all of them clinically acceptable or superior. Had a few there with the length of time. There's a couple there with the length of time that was deemed unacceptable. And one of those actually is matching, I think, with the ease of removal and the overall performance. I did find, though, that even though those patients were rating lower, there was some what's the word? Like, there was a bit of discrepancy, and I'll show you in my next one here. It was really difficult to understand because I had no patient with less than 3 days wear time. So I'm thinking that, as you can see there with the length of wear time, I had there was those 2 patients that did not that had clinically unacceptable. Yet one of them had 3-day wear time, the other one had 4-day wear time. So I'm thinking that maybe the nurse interpretation of the wear time of up to 7 days was not met because it didn't reach 7 days. I don't know. There was no comments on it, but I guess I'm assuming that. But either way, there was good wear time for the most part. One of the things that this slide here kind of highlights, I kind of wanted to put it in percentage, is that you can see for the overall performance, there was about 95% was clinically acceptable or superior, and there was 100% for ease of skin checks and ease of application, as well as patient comfort. And those are very important pieces because those also allow the nurses to, spend less time. They can check the area, and do their assessments as required by their job without having to remove the dressing. And I think that really was remarkable in regards to that score. So the next few slides here are, I will say, they are courtesy of Medline. These are the product, description and the product effects and what this product is about. So first of all, what is OptiView? It's a transparent dressing with hydrocore technology, which is a patented product of Medline, and it's used to prevent. And I will highlight that it's a preventative measure. This is not really something that we're going to be treating. This is to prevent, and that is the key focus. And as you saw from the guidelines, from the different associations, that prevention is the key to this. It has a unique transparent hydrocore island, which is that middle piece, and I'll show you on the next slide more specifically, but what this does is it draws away some of the heat that develops under the patients, and it helps optimize that microclimate that we talked about earlier. It also cushions, protects the area from forces that lead to the pressure injury, like friction, for instance. The other component is the one of the things that helps mitigate some of those key forces of pressure in development, like the cheer and the microclimate that we again talked about earlier with the best practice recommendations from NSWOC. And it comes in 3 different sizes. Those were the 3 sizes that I trialed. It is my understanding that there is a new one that's going to be coming out. But for now, those 3 were the ones that I had available to try. And this is what the dressing looks like more up close with the 3 key components. As you can see, multi-layer silicone dressing with the silicone contact layer. That's what goes in touch with the skin of the patient. Then that middle piece there with the hydrocore island that provides that microclimate control, the comfort and the cooling effect is what some of the patients that I had related to. They really enjoyed it because it had a bit of a cooling effect to it. And also it's transparent and waterproof, which makes it really good for long-term wear because the skin can be assessed, patients can still take showers, etc. And then also highlighting some of the key points here with the OptiView benefits. As I mentioned, the visibility, the promoting the skin checks without having to remove the dressing, allowing for early intervention. If something is to develop, you can see it right away. You will see some redness maybe develop if that's the case. And it definitely decreases nursing time with the skin assessment because they don't have to remove the dressing and then subsequently either put the same one back or a different one. So it's very quick check, very easy to check. It does have that extended wear time usage because of that, and therefore that can decrease nursing time per patient. And again, the cooling effect is another, I thought was a really cool, no pun intended, effect of this dressing because a lot of patients did comment on that when I was chatting with them. So just another slide here with the different types, and I think that one there at the bottom, the heel, is apparently a new one that's going to be eventually available. If not already, I don't know, but I'll let the Medline people inform you of that. But the one that I used the most was the smaller sacral one for most patients, with a few exceptions. So next, I'm going to go through just some of the photos that I captured with the trial of the dressing and some of that the changes that were done. So the first patient that I had in the trial was June 20. So this is back last year, June 27th. I got to see them on the second dressing change. So basically, nurses had initiated the dressing based on the criteria. So I didn't get to see that patient until afterwards. And then, so on the second day, this was on for 6 days, and it was starting to come apart. So they decided to change it, and they called me, and I went and saw the patient. So we put the dressing on. That's just the picture to show that same day what the dressing looks like. I did encourage the nurses to put down a date of a planned removal based on the 7 days. And then this is what it looked like on the 7th day. It did last the 7 days. You can see there's still some redness. This is a little bit of friction, I think, on that left buttock there. But overall, there's no worsening of the areas that I could tell. And then this was after a couple of dressing changes. I just went in to reevaluate the patient. and noticed that there's significant improvement of the redness. Still that area you can see, but it's dry there on the left buttock that was caused by some friction prior to the utilization of the dressing. And it was challenging to capture all the pictures because I was the only one really evaluating this and just relying on the nurses to contact me with either any issues or when they were including someone in the trial. But it was really challenging. They weren't independent and they did really well. I kind of wanted to see this because if this becomes part of a protocol, I'm not going to be there every time. The nurses need to be independent in managing and evaluating these dressings on their own. So another patient, I was a little surprised with this one because, again, the criteria was to be used on patients with intact skin as part of the evaluation that we were doing, despite the dressing being okay to use on minor skin breakdown with low drainage. But there was, you can see here in the coccyx area of this patient, there was an unstageable pressure injury. And the nurses identified this. They thought because it wasn't draining very much, that was okay to put it on, and they did. So, and the dressing lasted for 5 days, which I thought was pretty good. So I thought, you know what, why not? Let's see how this works. And we continued using the dressing on this patient, and you can see it covers the area very nicely and stayed in place really well as well. I have some more random photos just to kind of show you that, even upside down, the dressing worked well. You can see this photo here. The nurses actually placed it opposite to what they were taught, but it still lasted for 7 days on this patient. And this one here is just to show a patient that had a bit of a curvature on the back. You can see the reddened area of a stage 1 pressure injury that had already developed. And so the nurses started applying this dressing. Unfortunately, this patient was discharged about a week later, and I did not get a chance to follow up and see how the skin looked. And so this was back, most of these were back last year, and had a bit of a pause because of competing demands. But just more recently, after we did a pressure injury audit and prevalence study at our organization back in February, it kind of triggered me to think about, I still had some supply and continue the trial. So this is my most recent patient. Just a couple of days ago, patient was admitted. He has a history of significant skin breakdown because of, again, he has spina bifida, so you can see that's the spine right there. It protrudes a little bit, and he had mentioned that it's been an ongoing issue for him to have pressure injuries develop there and skin breakdown related to that. So I thought he'd be a good candidate, so we put the dressing on, and I have not, it's still on. I have not seen him yet, so we'll see how long this lasts, and if it does him well, and hopefully prevent something that he's accustomed to in that in preventing the pressure injury development that he's had in the past. So I'm now going to move to the pressure injury protocol. Now, I will say this is not in place yet. This is something that currently we use basically the best practice guidelines, that combination between RNAO, MClScWH, and NSWOC, hopefully to meet the criteria from Accreditation Canada for the ROP of pressure injuries. And so this is something that I'm working with leaders and other key stakeholders, other allied health, to try and develop a protocol for it. So basically, we start off with a grade and risk assessment, which is done on admission, regularly, weekly, and then when conditions change for that patient. So we're going to continue with that, continue with the skin assessments, which we do at every shift. So nurses do this Q shift to hopefully catch things early. And then if patients are deemed to have a moderate to high risk, I am considering using the OptiView on those vulnerable bony prominences. Haven't determined yet what the frequency is going to be. This is something that's going to be up for discussion with the rest of the team, but that is kind of the goal, to try and have a 5 to 7 day wear time, obviously depending on the patient condition and incontinence, etc. We are planning on establishing some repositioning and turning schedules that will be built into the system that will cue the nurses to as a task to actually do these, so that it's not just dependent on some doing it and some not. Hopefully, this will trigger some more utilization of that protocol. We'll continue. We already have a good selection of pressure redistribution services. There's an algorithm, a decision tree that is available to staff to help decide, when myself or the occupational therapist is not around, what surface is best met for the patients, depending on their condition. And then continued nutritional screening pretty much happens with everyone. So that's a piece that's just going to continue. And the interprofessional collaboration is something that we're engaging with, developing a committee that's actually has membership from the different disciplines to make these decisions, and such as the protocol and others related to pressure injury prevention. And lastly, a piece that is going to be reinforced is patient and family education on prevention of pressure injuries. And this also is something that's going to be tasked into the system, into the electronic system, to have documentation, so that we have something that we can work towards and make sure that patients are having the proper education, as well as their families or caregivers. In summary, we talked about different things here. We talked about pressure injuries, the fact that they continue to be a significant issue in healthcare. Pressure injuries are mostly preventable. There's a lot of data that you can see that WOCC Canada did, NSWOC, and others that clearly indicates that majority of pressure injuries are preventable. So we know this. We just need to work harder, I think, at creating those preventable or those prevention pieces. It's also costing a lot of healthcare dollars. So, maybe these are healthcare dollars that could be saved and used towards other aspects of healthcare. We talked about, the priceless issue for patients in the decreased quality of life for their families as well. Again, the reporting system, maybe not the greatest that we have. We need to be more consistent, maybe have more of a unified and more regulated reporting system in place for pressure injuries across Canada, across healthcare sectors, in order to have the more accurate data to make sure that we know the extent of the problem better, and hopefully emphasize those prevention protocols. And then, well-established guidelines, by all associations. We have them in place in government, but how well are they adhered to? And that's something that maybe the reporting system might help to work towards. Excuse me. And then, we talked about adding advanced dressings, such as the OptiView, and there's many others out there that can be an adjunct to the gold standard. They're not to replace anything that's currently done, but they're to add, another aspect that will help, because there's been a lot of studies showing that there is some benefit to using these. And then also highlighted the staff and the patient satisfaction with the overall performance of the OptiView dressing and the evaluation that I did. Was really great to see, and that's what kind of led me to consider using this as part of the prevention protocol that we're establishing at Parkwood Institute. What are some key takeaways? Well, pressure injuries remain a significant clinical and economical burden in Canada. The prevention requires multifactorial strategies guided by evidence-based guidelines. And there is a lot of evidence for the guidelines. There's a lot of evidence for these adjunct dressings to help, make them in addition to the protocols. And we need to reduce the prevalence. The prevalence depends on that early risk identification, system-wide protocols, and continuous education for staff, for patients and families. Really have to have an understanding of not only the consequences, but also what it takes to achieve positive goals within the pressure injury prevention. And just really highlighting this again, I want to make it very clear. This was an evaluation of a great product, such as many other great products out there that have a similar concept. But OptiView and those products are not a standalone tool for prevention of pressure injuries, but they are one that could be added to the toolbox as an adjunct to those protocols. And really want to highlight the two Canadian associations, NSWOC and WOCC Canada. They refer to microclimate, they refer to advanced dressings, respectively, as prevention of pressure injuries. And OptiView meets those. Like I mentioned, there are many dressings out there. Try them all. Do whatever it takes to make things better. This pretty much ends my presentation. I want to just highlight regarding the evaluation. I did create a poster, has a little bit more detail from that evaluation. I encourage you to register for NSWOC conference, and you'll see the poster there. I'll be there with it, and if you want to, personally ask any questions, just get yourself to Montreal.
Awesome. Well, thank you so much for taking us through this, Paulo. It's been great, and we've been getting some fantastic questions coming in. Maybe what we can do too, because I know you're on one monitor. You can stop sharing if you want. It might make it easier for you to see us in some of the questions. But I've grouped our questions a little bit here, so we'll see if we can get through as many as we can. First one, I'll kind of talk about a bit more about OptiView specifically. One of the questions we got were what would be your suggestion for preventing edges from lifting on dressings? Especially maybe in more of a moist environment.
So one of the criteria that we had was that we were using this as a trial with patients that were either not incontinent, or if they were incontinent, they were really more predictable. So they maybe had 1 to 2 bowel movements a day, or maybe they had a fluid catheter. So we didn't have a lot of rolling. We didn't have a lot of moisture conditions, because we kind of made that part of the criteria. Now, that's something to work with, something that maybe a next step in evaluating and seeing how well it does. So I wouldn't really know how to answer that based on those criteria, but I will say that what we did not have a lot of rolling. There was nothing really. I found it really interesting with this dressing. The edges, it seems to be tapered thinly to a point where there was less rolling that I noticed with this dressing in comparison to other silicone dressings that I've used in the past. Maybe because they were a little bit thicker and this one's a little bit thinner on the edges. I don't know if that's the case, but it certainly did not roll as much as some of the other ones that I've tried.
Fair enough. And then I guess just general guidelines or tips for making sure it is in a position to stick well and to not lift. I know, Monica, you're mentioning about making sure the skin is dry before applying there. Avoid use of barrier cream. Any other tips you might mention as well?
Yeah. So we did ensure that the nurses were cleansing the skin just with saline. There's nothing spectacular, pat drying. And then we were using a no-sting skin prep on the skin that was going to be under the dressing. So that was one of the things that I asked them to do, and maybe that made the difference. Again, this is not a controlled trial type of study, so I wouldn't know if that made the difference, but certainly we did not experience a lot of rolling.
Fair enough. Thank you for touching on that. So another question that we had here was about whether the OptiView can be used for all types of pressure injuries. We had a lot of questions about, is this mainly to be used for prevention? We had one question who was asking about, can this be used in the ICU for patients for prevention, especially for those with limited ability for repositioning due to hemodynamic instability? I wonder if you can comment on that.
Yeah, so I think first of all, no, I would not use this for every stage of pressure injury. I would use this more towards the preventative or the very early stages, such as 1 and 2. And again, 2, if there's not a lot of exudate coming from that. In terms of ICU, from my experience, I don't see why not. I would say that one of the criteria is for it to at least last. I think in terms of the effect, there's a lot of trials going on right now, and there have been for years in ICU patients with other dressings. And I think there's been good results. That's kind of why there's been this trend of using these specialized dressings and advanced dressings. So they are making a difference. And whether that difference is just the fact that you have a dressing there and you're checking it more often, so you're repositioning patients, or whether it's the dressing itself. But certainly incontinence becomes a big barrier to any kind of dressing. And if the dressing in a patient is not lasting at least 3 days, then I would say it's probably not being a benefit, because then it's going to trap some of that incontinence and maybe cause even more skin breakdown. So yeah, I would definitely use it in an ICU setting. I would use it, but I would not use it in all like a stage 3. I wouldn't use it as a cover dressing or as a treatment per se.
Gotcha, no problem. I got a question from Shelly about for the moisture barrier. Was there any moisture vapor transmission, I think is what MVT?
So I mean MBTR, yeah. So
Okay, thank you.
I I don't know exactly what it is. I do get a feeling that there is good MBTR, because for those that I did see myself, and I didn't see any comments on it, but there was a couple early on that I went to just take down because they're on day 7, and I thought I'd check it out. I didn't notice any like what we call like the little sweating of the skin underneath. I didn't see any of that with the ones that I saw. So I think that might be what Shelley's referring to, because I do know that just based on my understanding of the dressing, it does have a good MBTR.
Mhm. I
Thank
can
you
just
for
speak a
yeah,
little,
please
sorry.
do, yeah.
Yeah, go
So
ahead.
we do have a study where we've compared trapped moisture versus escaped moisture with traditional like silicone foam dressings. So if there's interest in seeing that, we're happy to send out that study so that they can see the results of that. But what we see with OptiView is that it is equivalent. There's no statistical difference between the MVTR versus or trapped moisture versus escaped moisture versus traditional silicone foams.
Fair enough. And would you want to just cut, as we're talking on the topic of moisture here, do you want to just comment as well? Someone was asking about using it on full thickness wounds. Did you want to maybe comment on whether that would be possible, or if again more preventative side for earlier stages or lower stages?
Yeah, and it's a great question because we've definitely had a lot of questions around that. OptiView is primarily a preventative dressing. While it can be used for open wounds with low drainage, it's really meant that, if you had a stage 1 or deep tissue injury that started to open up, you don't need to take that dressing off right away. You can continue on until you're ready to move to another stage of management for the wound. But it is primarily meant as a preventative dressing. Yeah. Thank you.
Yeah, and thanks for touching on that. Maybe we'll have got you here too. And again, Angela Douglas and Monica Stanfield in the background here helping us from the Medline side. I know we had quite a few different questions about people asking how can it be accessed? Can patients directly access OptiView through Medline? Are they available in Ontario? Are through Ontario Health? Are they or Health at Home, I guess, or through AHS? I just wanted to see if maybe you can comment on that.
Yeah, so we are on both of the MedBuy as well as Health Pro. With Ontario Health, we're not currently on the formulary. Patients can purchase directly through Medline. We have customer service that's available that can support. So, with Ontario ODSP, that could be covered. There's a number of different avenues that patients can access. And if anyone is interested, we are happy to connect you with your sales representative for your area.
Absolutely. And as just a reminder to everyone, we are going to be sending that certificate of attendance and the webinar recording to your emails. So what you can also do too, if you have a question or if you want to see and get access more close to you or get connected with a sales rep in your area, just reply back to that email too, and we can redirect you to Monica or a member of the Medline team. So please feel free to do that. What else do we got here? We got lots of good questions here. Maybe switching gears from the preventative side to a opposite end of the pressure injury spectrum. Paulo, someone was asking about what your experience has been, I guess more out of curiosity, but what has been your experience with unavoidable pressure injuries?
You just have to deal with them. You know they're going to happen. You do, you kind of ramp up some of those protocols, some of those guidelines that are being put out by the different associations such as NSWOC. I think you just have to be extra careful. But the issue is some of those unavoidable ones are things like that I've seen are people that have had like falls at home that have been unaccounted for, or they've been like laying on a floor on a bathtub um, for endless hours. You can't avoid those. Those just they are what they are. Also, patients with very lengthy surgeries, these patients often develop DTIs, deep tissue injuries, which in turn then turn into some pretty serious wounds. And again, it depends on the situation, but those are considered unavoidable because of their circumstances. And you can't put a padded OR table or one that has pressure redistribution, because then if they're doing brain surgery or they're doing heart surgery, you need to have that stability. So these patients will develop. I say just ramp up those guidelines, maybe have more repositioning, have the better beds, but really it's the same protocols, just prevention, the same as prevention.
Absolutely. And I think it's such a big topic here. And I know our Canadian Pressure Injury Advisory panel is always talking about it as well. We've done our summit on it, but do access the resources you can. I know Paulo has been talking about it today, of course. There are resources both on our NSWOC site, on our CPIAP site that I just mentioned too. But again, very, very important topic. And I'm glad you've had a chance to talk about it a bit more today. I'm seeing all the great comments in the chat here. Thank you, thank you, thank you from everybody. We'll see if we can just get to a couple more questions here. Question, I guess, both on the Medline side here. Someone was mentioning that they've seen a silver cloth of OptiView. Are there other types with the same name? Is this a different type of OptiView that's also available by Medline?
I'm not sure about the silver cloth unless they're referring to our Drygo, which is a hydrogen peroxide impregnated cloth for wicking. But outside of that, I'm not quite sure if I'm familiar with that product.
No problem. I did just, Marcia there, just answer that one there. If you want to reply to it for more context, feel free to do that. I'll keep this the questions open for a couple more minutes here. I know we've got a little bit more time. So if you've got some burning questions, please do feel free to bring it forward here. Jennifer Bilby was asking, when a patient is discharged, is OptiView listed as part of the discharge orders? And I think Jennifer is Ontario.
So this is, so when I was trialing this last year, the product was provided by Medline, and it wasn't available yet. So what happened was I would give the patients a couple dressings just to kind of continue, but really the education was really the piece. And that's for those that I was able to get to. But I think that might be something that I will actually include in our protocol, is factor in the discharge component, so that they can then hopefully either themselves or through the home care groups obtain the dressings if the risks are continued, because obviously patients come to a rehab hospital to rehab from a serious condition to be their normal, and hopefully if they are better, more ambulating, and they're better, they may not need it because then the risk decreases. But certainly that is something to consider for those that still maybe are transferred to another institution or home with the continued risk.
Thank you for touching on that. And I saw in the chat here, Jennifer saying, yes, that'd be great for follow-up. Fantastic. Alrighty, well, I'm not seeing any more new questions here, but I'll say, again, just re-echo the fact that everybody's saying thank you, great presentation, and a reminder to everyone out on the webinar here, it's recorded. We will be sending it to you in the next little bit. Final reminder is if you have any more questions for Medline, you can definitely reach out to them directly. As they said, they also have their customer service on their site. If you reply to the email, we can also get you in touch with Medline too, so feel free to do that. And I know Paulo already said it, but I'll reiterate it too. You can see on my background here, we do have our NSWOC 44th National Conference coming up less than 2 weeks away. We're almost there. We've got both the full conference and the daily registration rates available. If you do want to come and attend, Medline's going to be there. Be fantastic to come and stop by the booth. I'm sure OptiView, I'm sure you can ask some questions about OptiView there, as well as all the pressure injury prevention work that they're doing here. So with that, I'll say thanks again to Medline. Thank you, Paulo. And I know this won't be the last time we see you on a webinar or in person on another educational opportunity. So thanks again for your time and expertise.
Going to be in Montreal.
And you'll be in Montreal, yeah.
And so if anybody really wants to see my poster, come out.
Yes, and your poster as well. We've got a full poster library. Awesome. Okay, well, thank you both. Thanks, Angela. Thanks, Monica, for being with us today. And we'll see you all soon.
Thank you, everyone.